you're in the right place. Dr. Kris Wusterhausen has been in your shoes, and he's done the work and can show you how you can turn things around. In this podcast, he'll share his personal stories and advice on how to create the life you want for yourself as a provider and as a business person. You'll learn how to reclaim your life, your time, your energy, and most of all, reclaim the dream you had when you started your journey to become a doctor. Welcome to the Dr. Kris Podcast. All right, welcome back, Dr. Kris, to the Dr. Kris Podcast. How are things been going? We haven't talked in a couple of weeks.
Things have been good. We had an extended vacation, which was the first for us in quite a while. So it was awesome. I can easily say best vacation we've ever done. If anybody ever goes to the Virgin Islands, I give it 2 thumbs up. It was amazing. And then we've been busy. Last week, we didn't meet either because of opening Nashville officially. So we went down, and I actually have to say the ladies I work with, as they would like to say, did 90% of the work. I was just kind of there to moral support and move heavy things. They really did all the work there, but we got Nancy, our nurse practitioner, all settled in now in Nashville, and now we're actually officially open for business.
Well, let's give everyone a little backstory on what's happening here, because it's a great segue into our conversation today. But you have this practice now that you transitioned a while back from being a traditional medicine practice to a cash pay practice. And what we're talking about is that you're expanding and opening a new location in Nashville, Tennessee. Give us a little bit of that. What's going on more specifically?
Yeah, so this is a transition that's been going on for now 12, 13 years is when I started transitioning from that traditional model to that cash pay model, like we're doing right now and have been doing for many years. And we're outside of Fort Worth, Dallas, Fort Worth. We're just west of Dallas, Fort Worth in Weatherford, Texas, in Parker County, one of the fastest growing counties in the United States. And our practice has been growing, and we've been extremely happy. But I have a lot of ties to Nashville. I have family there, have customers there. We travel there frequently. We just simply noticed that there was a real void for the type of medicine that we practice in Nashville. And we were very surprised by that. You would think Nashville being Nashville, and if anyone's ever been there, I think they can understand it's a very techie type town. It's a very progressive type town. And I was very surprised when I started doing the research on providers like myself that there was really a shortage there. And so we started looking at that, and then just totally by accident, about 3 years ago, one of my great customers opened a wellness center in downtown Nashville, and we're very close to this person. And she, from the beginning, was asking me to come join the wellness center and open our practice there. And we would have been open probably 2 years ago if it had not been for the pandemic. And I think at times, I'm not claiming the pandemic occurred for us, but sometimes things work out for the better. It's given us a couple of years to get Maggie on board here, who's now been with us for over a year, to maybe get a few more ducks in a row. And I think the timing is just right now. And we've added a great provider, Nancy Boyden. Nancy is a provider I've known for quite a while now through SSRP. So she is an SSRP participant. So that's where I first met her. And she has had a practice in Washington State for many years that she's still running a few days a week, but is in the process of shutting down. She's relocated to Nashville and plans on doing Resurge full time as it allows. We're opening Resurge 3 days a week there, Monday, Tuesday, Wednesday, and as business increases, we'll eventually open 5 days a week. And it's right there on 17th Avenue, which is 1 block off of Music Row, and a old recording studio that's been completely renovated. I guarantee you, we had our bio-T reps in who were walking through our facility last week, and they're like, wow, I can promise you there's no one else like you in Nashville. And I go, yeah, there's not. I mean, it's an amazing facility. And we're really excited to be finally open there.
So these conversations that we're having with Dr. Kris on the Dr. Kris podcast is, there's all these providers, and there's something in the back of their mind that's been bugging them about, where's my practice going? Where's this traditional medicine going? It's not as fulfilling. It's stressful. I'm neglecting my personal life, my family, and that was the case with Dr. Kris. And last week we talked about the fear of the unknown. Is like when you finally make this commitment in your mind, I'm going to do something about this. I'm going to change my life. I'm going to change my family life. I'm going to change my professional life. And there's this fear of the unknown. And we really covered, what are the most common model, the legal stuff to consider those things. But today we wanted to talk about the financial hurdles. What's the most surprising thing that you learn when you start to really consider, as a provider, I've got to do something different. And so that's why we're discussing the Tennessee, the Nashville location, is that these questions are fresh on Dr. Kris's mind. And so when you realize, Dr. Kris, that, all right, I'm going to go from this traditional, it's like any other business, you got this steady income. Mm-hmm. There's this unknown. Talk to us about all the financial hurdles that were intimidating for you.
Well, and I think we covered it just a little bit in the last podcast, and that is that most providers, I think just most humans, don't want to take financially steps backwards. And you have to, early on in this process, make your decision. And are you willing to take a few steps back, maybe 4 or 5, to then take 10 steps forward over the next couple of years? Or is that unappealing to you, and do you want to somehow build a revenue stream along with your revenue stream until it gets to a certain point that you can just laterally move over into that? And that is the model that I chose. I think the negative of, obviously one model is, today I'm a traditional practice, tomorrow I am a cash model. You give your patients notice that this is happening. Maybe you give them 2 months, 3 months, 6 months notice, and whoever wants to join me, come join me. And this is what we're going to do on January 1st, whatever. And that can be very scary for providers, because they don't know if 0 patients are going to come with them or 300. And by the way, what's a busy practice? It really depends on what you're doing. But most functional age management medicine doctors, if you can have 300-ish routine patients, you have a busy practice. Let's compare that to a traditional model. Most individual providers are going to be looking for 2,500 patients, okay, 3,000 patients, somewhere in that 2,000 to 3,000 patient range is kind of what you're looking for a provider in the traditional model. So you're obviously looking at a much smaller number of patients. So, sometimes they really don't understand that. They're like, oh my God, what if only a couple hundred patients follow? I'm like, Jesus, that'd be amazing. Like, you would be doing great right out the chute. And why is that? Well, because your overhead is so much lower. I always give the example when I used to work with our county clinic here in town. And when I started, it was myself and a nurse practitioner. We had 2 receptionists, and we had an office manager and a biller. So we had, like, what was that? 3, 5, 6 employees. Okay. That practice grew, and I'm not sure where it's at right now, but it's somewhere around 5 providers and nearly 30 employees. Okay. And obviously the building's got to be much bigger. The utility bills are more, just the IT aspect of it is huge. You get such a bloated model of overhead that, when you see a patient, such a small percentage of that actual visit is going into the pocket of the profit margin. Whereas when you're a cash practice, when we started our conversion, we had a receptionist, an assistant, and myself. There was 3 of us, and my wife worked there as well, but I hate to say she didn't get paid. Basically whatever profits are left over was her pay. still kind of like that in many ways. But anyway, really, we were doing it with 3 to 4 people, and we were able to maintain that staff for quite a few years until actually we decided to move across town and go from a 1,000 square foot facility to a 5,000 square foot facility and add providers and services and things like that. So in the cash pay model, you can certainly keep your overhead quite a bit lower so that if you make $50, you're probably putting $40 into your pocket versus make $50, put $5 in your pocket. And so, but I chose the model of I decided to delete a day out of my week at my clinic. I was working for the clinic, and I have to admit, they knew that they didn't have anybody to replace me at the time. And so they graciously allowed me to go from 5 days a week to 4 days a week. And I started 1 day a week in my practice. And then I would also see patients at end of days and before, there was ways to work around it to where I would see patients here and there. And we also did some services that the nurse could do. That was a nice way of keeping revenue going, like Botox and Juvederm and things like that. So they were seeing patients when I wasn't there. And we slowly built that business up. And then, at some point, I don't remember how long into the process it was, I went to the practice I was at and said, I need to go to 2 days a week. And they graciously agreed, and I was able to do that. And then eventually went from 2 days to no days. What I would say about that kind of lateral shift is that it really slows down the process a lot because you're never fully committed, in my opinion. I think there is something to the heat being on a little bit, like, oh my God, if I don't make this work, obviously you're going to have some revenue in the bank. You're going to have a surplus, a cushion. I think most providers today have cushion in their bank accounts that they can afford to go 6 months, 9 months, 12 months without making their normal revenue. But I think there's a little nice heat that's put on you in that first model of just this switch. But I can't say that that's the model I chose. I'm a fairly conservative financially person, and I decided to go that other model of that slower transition. And that transition drug out for years. It really did. I still had that fear. Even when the numbers told me it was okay to do, I still had that fear of giving up something that was guaranteed, because I knew that if I went back to the clinic and said, I want to go back to 3 days a week, 4 days a week, 5 days a week, they would jump at it. So the net was always there. I never felt stressed about that. When I talk to providers that don't have that net, it's funny, they seem to progress quicker because they're more aggressive. They are, I'd look at the financials, but like, well, okay, this month didn't do that great, but okay, we'll go get them next month. Whereas if that's all I had to rely on, it'd be like, oh, hell no, we're going to have to do this, this, or this. So it probably honestly slowed us down 2 or 3 years. And there's some other financial mistakes that we made in the beginning that really hampered us that we could talk about if you want to, looking back.
Yeah. So I'm, in my head, I'm wondering, all right, I'm a traditional physician or provider. I have 3,000 in my practice, 2,500. If all I need is a 200 or 300, is it easy? Looking back, are you able to go, here's who you could expect to follow me? What do they look like? What are their outlooks? What are they expecting? What are the trends that are helping that?
So my conversion was a little different than your average physician. I converted from a county clinic to a cash practice. Okay. So being a county clinic, I had all types of patients. I had no pays. Well, I probably shouldn't use that term. People who could not pay that we saw because it was the county clinic. We had Medicaid patients, we had Medicare patients, and we had a smattering of, people with normal insurances that had normal jobs, some to even from upper middle class and above. So we attracted kind of all types. And I think this discussion would really just depend on what each provider's practice looks like. If you're in a affluent area with 85% commercial insurance with a ton of self-employed business owners, I think you're going to see a much higher conversion than you probably think. I was surprised at how many people followed me. I was expecting zero. Honestly, I just said, you know what? No one's going to follow me. It isn't going to happen. The most common people that follow me were self-employed business owners who, most of them, and I still say where our niche is the self-employed business owners who have overall poor health insurance, who have more what I call catastrophic policies, which is still what I have, which I haven't used my Blue Cross Blue Shield in years. It's there if there's a god awful illness, or I get in a wreck and, and I need $100,000 worth of surgery. It keeps me from, having to dig into my savings account, but it's not ever going to kick in on normal years. Also, the patients, those not always self-employed business owners, but a lot of them that understand there's a value in knowing that if my appointment's at 9 o'clock with Dr. Kris, my appointment's at 9 o'clock with Dr. Kris, knowing that I can get in and get out, get seen for what I need to be seen for, but being back at work by 9:30, 9:45. Or, oh, hey, I can't make it in today. Could I swap that visit real quick over to a Zoom call? Of course you can. We're not going to say no to that. You'll be surprised in traditional practices how many hurdles patients run into. And I always say, and I don't mean this bad, but it's always because the reception is like, no, we don't do that. No, we don't do that. I can't tell how many times somebody would walk up to me in a grocery store and say, I tried to get in with you today, but they said you couldn't see me. And I'm like, I didn't tell anybody I couldn't see you. But they would never come to me and ask, but yet I was the bad guy in the situation. My staff here knows that that's not going to happen. The only person that says no is myself. Because I have a saying, we'll stay as long as we need to get everybody seen. They see value in that. They see value in not coming into the waiting room and being in there with 20 other people and half of them are sneezing, coughing, hacking on them. They see value in that. And then they also see the value in those visits. I had a new patient today who I'm never seen. She happened to be getting her blood drawn. She's coming in next week, and she was referred by one of my great customers. And she literally said, you know what your patient said? And I said, no. She said, you got to come see him because he's going to dig deeper into your health than you've ever had dug before. And she's 64 years old, has just been doing the traditional model. And she's from, 3 hours away. And I said, well, let's get you established while you're here. And then we can do everything via Zoom, or you can drive up. She's like, oh, it's no problem. I don't mind coming up occasionally. But patients really are attracted to that model. Some are. As I always will tell patients, hey, you know what? I'll probably talk to 4 people and one person, this is for them. But guess what? That's all I'm trying to get is 1 out of 4. I'm not trying to get 4 out of 4. We don't need that kind of volume.
Yeah, volume. And plus, I can compare and contrast the relationship with you said customer, but they're also patients, right?
Mm-hmm. Yeah. So, I mean, my relationship, you know what? So, I had a patient the other day actually chastise me for using the word client. And he's like, I'm your patient. And I was like, okay. It was funny. His wife said, man, you're being kind of rude. Not me, the husband. She actually said, this is what the wife said. She goes, he just spent 45 minutes with you and gave you more information you've ever had about your condition. And that's what you came out of it, that he used the word client. So I don't even realize what I say sometimes. I like the word client. I don't know. I just like that term. But my relationship with my patients, clients, customers is, I think, usually much different than what they're used to. Certainly when I did traditional family practice, you have your pets, right? You're always going to be attracted to a handful of patients. And like, they were typically always my older patients, like, oh my gosh, I just love little Miss Smith. And my staff would even start to learn, put her at the very end of the day, because they knew I was going to be in there for 30, 35 minutes because I just loved little Miss Smith or whatever. But those were few and far between because you simply couldn't survive your day if you gave each patient 30 minutes for an established visit. I probably had 1 or 2 a week that was like that. I probably total had 30, 40 of those type patients that you did have that relationship with. But I honestly can say that I think nearly all of my patients, I know more about them than what they expect. We actually have real relationships. I had a patient the other day. She's not even one of my concierge patients. She's just one of my hormone patients. But she unfortunately got cancer recently. And she said, my family doctor talked to me about it, but I don't know what he said. And I said, do you have your reports and stuff? And she's like, yeah. And I said, come in, just come into my office. Let's sit down and let's just talk. I'm not going to charge you for it. She's a good customer here. You know, you could tell the family practice doctor meant well, but somehow they just, and she goes, you know, you just have a way of easing my concerns. And I just would like for you to, you know, give me your 2 cents. And luckily everything on her, she's going to do great. It's going to be a complete cure. Everything's great. She just needed somebody to really kind of figuratively hold her hand for 15 minutes and really just let her talk. And, you know, again, I know the doctor she sees is a great doctor. This is not an insult to the other doctor. He most likely just didn't have the time to really sit down and have that conversation with her, you know. I do. And that's what I really, really like. I went into medicine to spend time with my patients. You know, you've heard me say it over and over. One of my pet peeves, and I'm not necessarily anti-Obama, but he's the one with Obamacare who literally said, and nearly word for word quote, doctors should be happy. They're going to get to see more patients now. And again, very few doctors, unless you're just starting your practice up, are looking to see more patients. They're actually looking to give, I truly believe every doctor, or at least 98%, wants to actually see fewer patients, but give better care. They want to be able to, at the end of the day, say, wow, I made some differences in some people's lives. You know, I talked to you earlier before we got on for the call that, you know, I just finished up some lectures, and, you know, one of them we're putting some case studies together and actually able to show, like, look how much we did even on paper with this person, you know, in 6 months. You know, we just easily, at least, you know, if they don't get hit by a bus, probably added a decade of life to them, you know, and good life, hopefully. I just never really got that feeling when I did traditional practice.
Wow. That's so emblematic. You were talking about the other doctor, good doctor, and she just needed a little more time to help process and understand. I always say that's what I enjoy about you, is that it's not talking to, well, it's like a doctor who doesn't get annoyed by our questions, that we just want to understand.
And, you know, also, I would bet you, even though this guy sees her probably more frequently than I do, I know her better than he does, because when she comes in, I spend 30 minutes with her every single time she comes in. And heck, I like to just ask, what's going on in your world, you know, and they'll talk about grandkids and family, and, you know, and I enjoy letting them talk for 5 or 10 minutes about that kind of stuff. I generally want to know what's going on in their life, and I try to do a better job of remembering some of those things, so when they come back in, we can pick the conversation up where we left, and then we get to the medical stuff. You know, I was always bad in my traditional practice with doing too much of that already, because I like to know my patients. I really do, because if I can find a common thread that we have together, we will bond. And, you know, like the other day, my guy's like, yeah, I have a few Santa Gertrudis. Like, hey, I've got Santa Gertrudis cows, you know? And so, you know, we've got that little bond that we can always talk about and stuff like that, you know? I'll tell you one thing that I noticed when I first went into family practice, and my first year out, I worked at the small clinic in Springtown. And I know, you know where Springtown is, because we've talked about it before. And my practice was just starting. They added a second provider. It was kind of a slow, progressive climb. And it was more rural people, right? And patients used to bring me stuff all the time, like a pie or a dozen eggs or whatever. And I always thought that was so cool. Like, wow, they thought enough of me to bake a pie for me, or to actually say, I want to bring Doc a dozen eggs. And I know it's little bitty stuff, but I always thought, wow, that's so cool. And we get that here. And then, so I moved to my new practice, and we got really busy. And you never saw that anymore. Like, no one ever brung you anything. If they did, they brung you a letter talking about how much they hated you or something, you know, like we would literally get these letters. It was always about the staff, like, your staff sucks or whatever, you know, and it's like, oh my God. It wasn't even my staff. I was, you know, working for the clinic, but anyway, but like here, our relationship is such that people bring stuff by or like, hey doc, I saw this at the wellness center or at the health food store, and I thought you might think it was kind of cool. And so I bought you a bottle to look at it. Tell me what you think. And I mean, those little bitty gestures mean so much to me because it means we're making an impact on their life. They're thinking, they're thinking about me, but they're thinking about, what would doc think about this, and I think that's so cool in our practice that we have that.
Well, I think when someone goes to the doctor, whether they admit it or not, there's this impact of this decision and their family. And you're addressing that, you're touching on that. And that's why it feels better to them, I believe. Let's talk about location. Obviously, what are the considerations of a location? If I'm a provider, I'm thinking about this. What are the trends that you're seeing now? Are there things that are available now that weren't when you decided to make this move?
Well, so one of the other things I tell new providers when I'm talking one-on-one with them is that I probably chose a not so great location. If you really just look at it from a business standpoint, if we're just judging it from business, okay. Even though my county is it's now a very fast growing county. Whenever I started this, it was not so fast growing. And probably if I just was like taking out a map and saying, where am I going to put my clinic? I would choose something like, I don't know, Nashville, versus where I'm at. And why is that? Well, the county I'm in is still fairly rural. It is growing very fast, but it is a very have not community. Patients in my community is more upper middle class to very wealthy, to not, very much below middle class, lower socioeconomic standing. So demographically, I don't know that like where my practice was the greatest decision overall, but guess what? It was home, and we've made this our home, and it's going to be our home until we die. And so we're not leaving here, so obviously your demographics are where you're at, make big decisions off of, like in the Metroplex we're at, if you're in, I don't know, University Park, which is like where H. Ross Perot and Mark Cuban live. You might feel better about doing a practice like this, but you also have to remember too, that you probably have a lot of competition in an area like that. That's why we were so surprised with Nashville when we did the search that there weren't that many people doing it, because I bet you if I Googled University Park and that kind of area, I'd probably find 8, 9, 10 doctors doing at least similar things. But there's probably also the population to handle that kind of stuff. So I think the demographics is just something you have to really look at this like a business, not as a practice. And it's something that doctors aren't always really good about, is being a business person. And you probably need to, just like if because you do our marketing for us, you're looking at certain demographics to see if that's worth the money to market towards that. You need to do that research, see how your area looks. Is maybe where I'm at not great, but maybe 5 miles to the west much better. You need to really make those judgment calls for yourself. And I think all I would say is what's available now, it wasn't then able then, is that you have that ability to do that research and do it very, very simply. When I did this 12 years ago, it wasn't so easy, and no one ever broke it down that simple to me. I probably would have still done what I did, but because my situation was what it was. But our growth of this facility has maybe not been as quick as what we're expecting in a town like Nashville. We're happy with our growth. Nobody's complaining. But if you're in an area where it's just got unlimited growth potential, obviously that's always going to be superior to maybe somewhere that doesn't have such unlimited growth potential.
I was watching a documentary on megatropolises or whatever, and from Houston to Dallas to Austin, and then in that they said to Weatherford, and it was like
They did?
Yeah, one of the biggest population centers in the States, and anyway, I giggled when they said Weatherford.
That's funny.
The other thing I think that's different now than when you started, Dr. Kris, and we're talking about location, is you have a lot of people that travel to see you, and you're able from an initial visit to work with folks anywhere, right?
Yeah, and that's a good point. When we started this Zoom, I mean, come on. You had to physically see these people, and then you would maybe call them on the phone and discuss things with them. But I say the other thing about the pandemic, there's been a few good things for the medical field in the pandemic, a few, not many, but a few. And one has been the standardization of telemedicine. You know, doctors are comfortable with it, patients are comfortable with it. Telemedicine's never going to go away now. Medicare and insurances are still, well, we're going to keep approving telemedicine for now. Like, it's going to be here forever. We've now realized there's so many things that you don't have to physically go into your doctor's office to do. I mean, you just don't. And that convenience of being able to, I still need to do that face-to-face new visit. But then after that, we can easily see them by Zoom. And, I say, hey, can you meet back up with me about once a year? Oh yeah, I can do that. That's no problem. Yeah. And it's good. I still always, and I tell my patients, I will always prefer a face-to-face visit. There's just something that I feel is lost over Zoom, but it's certainly a doable thing. And that's a nice thing, is that, with telemedicine, that can be, and there's docs now doing what I do that only do telemedicine.
Wow.
They do the whole practice telemedicine. Their overhead is practically nothing. I mean, they don't even have to have a scheduler if they don't want to, but most of the time they'll have a part-time person to schedule for them, and they choose services that are all doable via telemedicine. And that's what they do for their practice. They can do it in the afternoons off, or in the evenings, or at lunchtime, if that's what they want to do. And that's not something I'm real privy to, because it's not really my model as far as that goes, but that's an easy way to transition, low cost, like practically no cost.
All right. So last, what I wanted to cover today in general is like equipment. Obviously, there's a lot of opportunities in cash pay that aren't available in traditional. Let's kind of touch on that, maybe a little high level, and then we can reserve some specifics for episodes later.
Well, and so that's my biggest touch point on converting over, is overhead and equipment. And I mentioned to you earlier, there was mistakes we made. And the mistakes that we made is that we went way too deep with equipment from the start. We had this thought that, let's invest a lot into all these machines, and man, we're not going to be able to beat these patients away from our practice. We're going to be so busy. And, we stuck ourselves with probably, I don't remember the exact number, but probably somewhere between $500 and $7,500 worth of payments a month on all these machines, right? And that's a big overhead. And these days, those machines that we bought 10, 12 years ago are triple the price now. I joke, lasers and such, I'll use that term generically, could be anywhere from about $50,000 to $80,000. Your machines today usually start at 200,000. Like, it's very, very rare that you have someone come in that doesn't start or have a number greater than $200,000. So I used to say you could buy a house for that. Now, maybe not so much, but at least half of a really nice house is this little machine sitting in a corner. And you don't get to pay it off over 30 years. Typically that's a 5-year note. And it could easily be $5,000 now for a machine. And there's all kinds of machines, like just for us, we got into laser hair removal and facial rejuvenation, like fractional lasering. I won't go through the whole list, but easily today, well over $1 million in equipment. Probably then was probably around $500,000-$600,000 worth of equipment. And we would have been so much better off. Less is more, is what I try to tell providers. Like, again, go get the education, find things that you love to do, find things that require low overhead, like hormone replacement. Hormone replacement can be a no overhead or very low overhead practice. It's really hot. Maybe your fillers and Botox, if you like to do that. Yes, you have to buy the fillers and the Botox, but that's it. And once you sell it, you've made profit. I always say your first shipment's the only one that ever you lose money on. The rest of them, if you're reordering, it's because you sold it and you probably made profit enough to buy the next load of stuff. So once you get too deep, you're in the money. There's just a lot of a lot of procedures, services that you can do that are low overhead, or at least the overhead is not really seen until you actually do the service. And then as you build up your practice and you truly have done your research and you feel like you have the demographics and the patient volume to provide a service, then add it in. I think that's a great way to go. I've had a friend recently do it exactly the way I did it, and he's really struggling, because he didn't have the patience to back it up. That's why in Nashville, even my new provider is like, we're not going to do any machines. I'm like, no, not from the start. We're doing none. We're doing hormone replacement. We're doing peptides. We're doing a little bit of injectables, and we'll build it from there. And in a year, we'll rejudge. And if we want to add some of these services, we'll talk about it. And I've always told you, and I know you agree, you can do too many things. What's that old saying?
Master and a jack.
Yeah, like jack of all trades, master of none, or whatever that saying is. I don't want to be that. In our practice here, we made that decision about 2 years ago to downgrade our services, which is something you rarely ever see, is downgrading your services. I still have a few things that I like, okay, but I've got payments on machines. If I didn't have payments on machines, they would be gone. But we keep doing it. And once those machines are paid off, then they'll probably go away too. Or if somebody offers me enough to take them off my hands, because I just think that being really good at 4 or 5 things is a better situation than being pretty good at 15 things. I used to be really infatuated with, oh my God, I don't want to lose that customer to Steve down the street. Man, if you treat them right and you do a good job, they'll come back for your services. And if they don't, then they weren't the right patient for me. That means they're going to hop every time for whoever's $50. That's another thing. I really got caught up in marketing. Oh my God, the place down the street is offering a similar service for $100 cheaper or whatever. And somebody told me once, and I really, the price of our ticket to our movie sometimes can be a little bit more expensive because, as you know, the amount of I calculated up last year, we spent $34,000 on my CME training. Okay. I would bet you most providers spend somewhere in the $2,000 to $4,000 range. We're in the upwards of 30, and that doesn't even count all the stuff that I got paid to go to give lectures, that I got that education for free. I mean, we're constantly going to conferences. And he had a great analogy. He goes, it's okay to charge more for that ticket because of all the extra money that we've put into our education. And that's the one thing, is like, they'll say like, oh, so-and-so down the street is $50 cheaper than you. And I'll be like, cool. Okay, that's fine. Good. You have the choice, because what they're trying to do is say, well, match it, right? Like, okay, I'll match it. We don't match it. That's great. If you feel like I don't give you value enough that you're getting $50 more value in our service, then you're more than welcome to go to that customer or company down the street. And so I really had to work through that mentally, like quit trying to match everybody else. Because I had another person that told me once that there's 3 places you can be in a business. You can be the cheapest, the most expensive, or you can be in the middle with everybody. And the one place you don't want to be is in the middle with everybody. You either decide that I'm going to sell as many cars a month as I possibly can for a low profit margin, and that's how we're going to meet our needs. Or I'm going to maximize profit margins, but I'm going to sell only the high-end cars, and I'm only going to sell this many, but we're going to make our profit there. You just don't want to get mixed up with being in that middle bunch where you're just like everybody else.
So, I'm just thinking while you're talking, how different that conversation you just had with us is for a physician in a traditional practice. That's none of those thoughts, none of that freedom, none of those options are available because everything's being dictated by the insurance company.
You don't have a way to differentiate yourself in the traditional model. People sign up to come see you without ever, and actually most of the time they don't even sign up. Their insurance company sends them a card in the mail that has your name on it because you were the next one in the queue to get a patient. They have that right of calling and changing. Most of the time they don't. Like, oh, okay, Joe Blow is my doctor now, and they call and make an appointment and they go in and they see that doctor and that's their doctor. That's how they make their choices. Sometimes you'll say, oh, who's your doctor? Oh, I really like so-and-so. Oh, okay, I'll make an appointment. That's not that often. Most of the time it is because you either took their insurance and no one else did, or their insurance company assigned you to them and that's why they're there. And so,
Wow.
it's how they get doctors.
So, it feels like when you're talking, this is more fulfilling. You're looking at things more as a business person. You're looking at things more as relationships, and you're impacting lives. Obviously both sides, but it's more of a, I don't know, a fulfilling thing that I think most providers signed up for when they wanted to become a provider.
Yeah, if I could say one last thing, and that is that I'm just as busy as I ever was, but my day consists of a totally different looking day. I, spend more time with my patients. I actually spend a tremendous amount of time researching things. I actually have academic time in my schedule where I literally look at new studies, read. There was no time for that. I always joke, when you're a traditional doctor, unless you were just better than I was, and maybe you were, there was no time for that. I didn't have time to sit down for 2 hours and research things. My door was constantly being knocked on, or if I did have a patient cancel, all that did was make up the 45-minute gap a little bit that I was behind. It just didn't exist. I didn't get that kind of time. And that's another big thing that differentiates doctors like myself, is we actually have the time to be able to research the new trends and really stay in front of these things. I got all of my knowledge from two places when I was a traditional doctor. My drug reps that came in and told me their side of their drug that they had in the studies, and the one time a year that I would go to a conference for 3 or 4 days and get a little bit of information there, and little spot headlines here and there, but nothing like today. I mean, we spend so much time on education. It's just, but I really, the more I do it, the more I enjoy it. It's how we put our lectures together, those sorts of things.
All right, Dr. Kris, if I'm a provider that's been listening and I'm still, I'd like to talk to someone a little bit more, what can they do if they want to talk to you?
The easiest way is just shoot me an email. That would be my preferred method. Dr. Kris at theresurgeclinic.com. That's DRKRIS at theresurgeclinic.com. And I'd be more than happy to have a complimentary, courtesy call with you, just discuss your situation. I do it frequently. I don't mind that, usually about 20, 30 minutes, and just see if I can give any insight on where you're at.
Yeah, and then soon he'll have some other options to offer folks that want more. So, Dr. Kris, this has been excellent. I really enjoyed this, and I'm sure the folks that listened to it. So, stay tuned. More episodes coming. You can check out Dr. Kris more at drkris.life. That's DRKRIS.life. And we'll see you on the next episode. Thanks, Dr. Kris.
Thanks, Steve.
Thanks for joining the Dr. Kris podcast. If you learned something today and you want to connect and get more information, visit our website, www.drkris.life, where you can find more great information or even schedule a time to learn how you can engage with Dr. Kris. Be sure to follow, like, share, and we'll see you on the next episode of the Dr. Kris podcast.